Good evening, everybody. Welcome, welcome. Here we go. How's everybody doing? Wonderful Tuesday night. Good to be back. Great to be here chatting with y'all. Another busy week. Another busy week of stuff, especially the NFL world. We had a lot of stuff that happened this past week that we will dive into and take a look at. So, as we're letting some people fill in here, again, as always, we'll go through updates on recent videos. We will talk about, in particular, the two big recent ones that we had over the weekend. Quinshon Judkins, his ankle, we'll go through some updates on that. Turns out one, unfortunately, was wrong about. I was hoping I was going to be right just because of injury severity. But we will talk about his, ankle injury again. If you've got any questions, of course, the Pat Bryant spine injury mobilization stuff that occurred. I also have Alexander, is it Isak for Liverpool, his ankle injury that we'll talk through here as well that I did not get a chance to cover on the video. So lots of stuff to talk through and plenty of great questions. Welcome. Thanks for joining. Thanks for becoming a member here. Appreciate it. Happy holidays. Yeah, getting ready to spend some good time with family here. So I hope everybody's traveling safe, having some good time with their family members this holiday season. Welcome, welcome. Happy holidays. Thank you very much. All right. So let's just go ahead and get diving into stuff here. Remember, as usual, if you want to head over to the, let's get it loaded up here. If you want to head over to the community page on my channel, you can comment over there on questions you might have for today. We'll get to those kind of second priority. So goal, right? Make this open. Everybody who wants to ask questions. If you want to participate in the chat, join for the membership. We'll get to those questions as kind of our priority. And then we'll go over to the community page and take a look at the questions that are over there. So if you want to go put some questions in over there, great. Stick around. We'll get to those as well. And again, plan on 30 minutes, an hour. We'll just kind of see how many questions everybody has and can get into some stuff here. First question, let's just go right to this. Let's see. Let's get this out of here. Record of torn Achilles tendons in NFL season. I have no idea, actually. I really don't know. Yeah, I have no idea what the number of Achilles tendon tear record would be. I wonder. Let's see if any of these. Let's see if Grok knows. If you guys want to follow, so for the NBA, Jeff Stotts is a fantastic follow in the NBA, in Street Clothes on Twitter. He's fantastic with all this data. For the NFL, I don't know of anybody who really keeps a strong, pretty high level database in the NFL. This is interesting, so I'm just flipping through some of this over here on Grok. This says 22 injuries in the 2023 season for the Achilles. Obviously, 2025 is yet to be done. 22, that was when Aaron Rodgers, Kirk Cousins, and then a lot of other players that we haven't heard about. So early 1980s to 2000s, 2023 in recent years. Yeah, it's an interesting question. I don't know how accurate that is or not. I think there's a lot of things at play there. I think, we talked last week about kind of the biologic age of a tendon. And I think the biologic age of tissue is accelerating quicker than the actual appropriate year in somebody's career, if that makes sense. So I think if you look back historically, and you got to think too, right? Sports are relatively young, right? I mean, you think about the overall history of history. Sports in the last 10, 20 years are drastically different than sports were the previous 60 years before that. And I think what we were seeing in that kind of 1980s to 2000s window, number one, we didn't have great ways to track all the data. And so I think there were probably more injuries happening that we just didn't hear about. Now we hear about every single one that happened. So there were some historically that we were missing just because there wasn't as much information, right? You were having to rely on a newspaper back in that day, and players that were on the practice squad, players that were lesser known, that wasn't going to get reported. So I think there's a huge bias of what was being missed in the reporting early on compared to what we're seeing now. Every single time there's a transaction, right, it's on social media, whether it's a practice squad player, backup to the backup, etc. So I don't know how much different it truly is. I think though that the biologic age of the tendon is the biggest thing that I would think about for what could be, kind of accelerating the incidence of these. And I think it's the same in the NBA. I think in the NBA, tendons are aging faster than what we were used to tendons aging 10, 20 years ago because of just a cumulative load on the sport, right? Guys are faster, stronger. There's just more demand put on tissues. And so I think that's contributing to why there's more Achilles injuries. But again, how much of this is just like a short-term spike versus an actual big trend? I think those are big things that are yet to be determined. So good question. Maybe someone can fact check that for me and let me know next week if that seems accurate or not. Welcome. Appreciate you guys joining. Let's see. Happy holidays. When it comes to Achilles ruptures, why might having surgery immediately have better chance at recovery for athletes? P.S. My girlfriend is med school at KU year 3. Big fans. Thank you very much. Year 3 of med school. So yeah, that's, oh boy, third year was probably the hardest year for me. Third year, typically, for those that don't know, third year is usually the year when you're like diving into your clinicals and you're spending all this busy time in the hospital. Fourth year, you get to do a lot of fun electives. So third year, very busy year. It's kind of oftentimes your first exposure to what it's like to be in medicine. So good question. I don't think we know for sure to answer this. When was it? It was Tatum, right? Tatum who had his surgery just like a day or two after it happened. And that was kind of unprecedented. And so far, it seems like Tatum's recovery is going really quickly, but we don't know that 100% to say, oh yeah, without any doubt, that's the better way to do it. So we don't know. I think to be determined. I think what we'll probably see over time if Tatum's goes well is you'll see more players have it done very quickly. Daniel Jones, I think his was done like a day or two later as well by I think the same surgeon that did Tatum's and did Halliburton's. So to be determined. I think there's a lot that goes into it. The longer you delay, there's kind of this window of time where there's a lot of swelling that happens. So the tissue bleeds. When the tissue bleeds, that blood accumulates, and sometimes that can cause stiffness. If the ankle is really swollen, it can be really hard to safely stitch the skin back together because then when the swelling kind of comes back down, there's going to be issues with how that skin was healing when it was sutured. So ideally, surgeons like to have minimal swelling in the limb when they go and do a surgery, and that might influence the decision to do it right away or not do it right away. But I don't think we know. The big thing with knee injuries, there was some kind of anecdotal, a little bit of literature data back in the day about ACLs for the knee, where there was theoretically this higher risk of what we call arthrofibrosis, where the joint gets like really stiff and fibrotic after an ACL surgery if it was done right away. That hasn't really seemed to play out as much as we initially thought was going to be the case. And so that's why you're seeing more and more like the ACL guys have surgery sooner. The difference with Micah Parsons and Patrick Mahomes, his LCL injury needed fixed, and that needs fixed quickly. So he had surgery right away, more so because of the LCL than anything. Parsons hasn't had surgery yet because likely he has an MCL sprain or something else that they're giving time to heal before they go in there and do surgery. So when you hear about why surgery is delayed or not, trust the surgeons. If it's right away, that's either because something needs fixed right away. If it's delayed, that's usually because they're giving time for something else to heal. So I think to be determined, I think probably there will be something where it's better, but it's hard to know with just one or two cases of this. But I think that'll probably become the new norm until we learn that it could be harmful. So any data studies on the longer-term durability health of players that get the speed bridge surgery that players like Tatum and Halliburton got compared to the traditional Achilles repair? Yeah, so let's talk about that here. Let me pop up our anatomy model. We're going to throw this over here so people can still see this question. So let's go down. Let's pull back in our tendon. Let's get to that muscular system. Maybe. Sorry, I'm trying to get the gastroc and the Achilles here so you guys can see connective tissue, right? I don't know why this isn't wanting to work. Let's try this. So the difference with what I think everybody's referring to there is Yeah, here we go. All right, sorry for that little bit of delay. So a traditional Achilles repair here, let's get rid of some of these bursa. We don't really care about any of those. So here's our Achilles tendon, and the Achilles tendon goes down and inserts into, get that centered, inserts into the calcaneus. Whenever the Achilles tears, the traditional way to repair it is to literally just take the two ends and sew the two ends together. So only put suture through the two ends that were torn. This newer technique that I think Arthrex in particular has, there might be other companies that are doing something similar, is they put anchors down into the calcaneus bone to then also like loop through the tendon and come back down. So you're getting an extra stabilizing piece of equipment in there. You're not just relying on the two ends of the tendon fusing back together. You've got this indirect connection that goes down through the bone, and that connection down through the bone is what helps to keep just a little bit more strength in the primary repair. And I think this trend is in a lot of orthopedic surgeries where they're using these internal bracing techniques, is sort of what they call it, to provide additional support in the early stages, which we think is going to help facilitate quicker rehab and recovery, because you can do more quicker because you're not as worried about the repair failing. So that's the difference, is there's secondary attachment and stability from the bone being involved than just the two ends of the tendon being repaired with one another, if that makes sense. Good question. Let's see. How much does poor biomechanics like patella tracking lead to acute injuries? Biomechanics in general lead to a lot of injuries. You know, I'll answer your question about patella tracking in particular. So the patella, there's not much you can do about the shape of your trochlea. The trochlea is a little groove that the patella, the kneecap, slides back and forth in. And some people have a very flat, or what we call dysplastic trochlea, where it's very flat. There's not a big deep groove, and so if it's very flat, it's easier for the kneecap to slide side to side. Other people will have, let's just go back and look at this, right? That's why we've got it pulled up here. So let's go look at our patella. Couple things that we take into consideration, right? If you've had a kneecap dislocation and what could be playing a role in what we decide to do for surgery or whatnot. Number one is going to be the trochlea, the groove. So the groove on the back of the front of the femur, where the kneecap slides back and forth. What's the shape of that groove? The second thing that we'll look at is what we call the tibial tubercle to patellar tendon offset. So if you imagine like a straight line coming down from the tip of the patella down to the tibial tubercle, this is where the patellar tendon inserts. Some people, it's like this really weird angle where it's off like in this direction. And if it's offset out to this lateral side, that's going to put more lateral pull for the kneecap to go out lateral. So those are the two common anatomic factors that influence. Oh boy, sorry, this is all goofed up. Those are the two anatomic factors that influence like something like a kneecap dislocation. And just, yeah, absolutely in general, biomechanics can contribute. If you've got muscle weakness, the muscle's there to help stabilize the ligaments. And if you've got muscle weakness, that can absolutely contribute to some of these injuries. So without a doubt, yes, those can absolutely play a role. Difference between knee meniscus and cartilage and the purpose for those not familiar. Yeah, good question. All right, let's. I don't know why this is pulling up two of these. Let's see. There we go. All right, let's get rid of a bunch of stuff here in our model. We're going to hide the muscles. We're going to hide. So really you can think of all of them as like stabilizing supportive tissue, the cartilage and the meniscus. So the cartilage is going to be what directly sits on top of the bone and covers the bones within our joints. Cartilage it's made of collagen. It's this protein, and it's a very strong substance that's able to withstand repetitive load, repetitive load, repetitive load. The bone alone is not able to withstand the repetitive load of running, jumping, walking, etc. The cartilage is there to help facilitate kind of stability and bear the load of our joints. The meniscus is also a type of cartilage. It's also made of collagen that sits as like a little cushion inside the knee joint. And what it's trying to do is distribute the weight as one part of its role. It also helps with stability. But the big thing is weight distribution. So if you take a curved surface and you take a flat surface, you get one little single point of contact. That single point of contact causes really high contact pressures because all that force from your walking and your weight is being transferred through that one little tiny point of contact between a curved surface and a flat surface, like a tangent point, if you think back to your physics. When you take your meniscus covers that curved surface, and so now you increase your contact area, and that force can be distributed over a greater contact area. So that meniscus helps to distribute the load across a greater surface area, which is going to decrease those contact pressures in any one particular spot. And so that's the role of the meniscus, specifically different from the cartilage. Good question. Great question. All right, let's keep scrolling down here. Let's see where I'm at. Primitive reflex. Yeah, great question. What do you mean by primitive reflex when it comes to the fencing position? I might be overthinking it. You are not overthinking it at all. Let me pull up a picture. TNR reflex. So one of the primitive reflexes, basically when babies are born, we have what we call these primitive reflexes, and it's primitive, just like that word means, where the neurologic system does not like understand what it's supposed to do, and so it just does some reactionary reflex that it thinks it's meant to do to kind of protect itself in a way. One of these is called the ATNR, the asymmetric tonic neck reflex. And so I'll pull up some examples of that. And this is basically what it is. Whenever babies, like their head goes to one side, sometimes you'll see this when they fall, their arm like goes out towards that side, and we think it's a protective mechanism to help stabilize and prevent a fall. There are some others. There's something called a Babinski reflex, where you stroke the bottom of the foot, and when you stroke the bottom of the foot, the toes curl a certain way. And so as these reflexes start to disappear, your neurologic system starts to develop, and the movements become more intentional and volitional. Because they are primitive, there's no like conscious control over them. And so whenever you see the fencing response, for example, now this isn't like 100% proven, but what we think is that it's like a recall back to those primitive neurologic pathways, those reflex pathways that are built into our anatomy that get triggered. So in the case of the fencing response, it's like this activation of this reflex position from the trauma to specifically some areas of the vestibular nuclei in the brainstem. So vestibular is what controls position in space and sort of your awareness in space. And so we think it's like an activation of that vestibular center that prompts muscle firing that's somewhat analogous to this primitive reflex of this ATNR. Again, I think the big point to take away from that is that when you see the fencing reflex, it's an involuntary thing, right? It's nobody's controlling it. They're not doing it on purpose. Your brain is constantly doing things in the background without you intentionally thinking about it, right? You walk, you run, you fire muscles without ever intentionally thinking about doing it. And those pathways are just going on their own. But when you have a brain injury, you get this sudden surge of electricity, right? These neurons activate through the brain and then discharge. And that can fire some of these pathways that we can't control. So primitive reflex, there's a lot of them. You can Google and look up primitive reflexes. When you're going through medical school, you have to learn like at what age these appear, what age they go away, and think of them as reflexes between the brain and the spinal cord that manifest with body positioning. So hopefully that answers your question. Ooh, applying for ophthalmology. Good luck. That's a tough one. Great quality of life, good field to be in, but definitely competitive and busy. So good luck. Good luck to her. Thanks for supporting the channel, both of you. Love it. All right, let's see. Yeah, you're welcome. Thanks for having these office hours. Yeah, I appreciate it. I enjoy the teaching. It's hard to know like what to teach and talk about unless I get feedback. And so having feedback from folks is really nice because I can focus what I'm teaching and what you guys want to learn about and do. What can repeated Achilles tears lead to down the line? So, boy, repeated Achilles tears? I'll be honest, I don't know offhand of an elite athlete who's had a repeat Achilles rupture. Yeah, if anybody's got one they know of, definitely put it in the chat because I'm not specifically aware of an athlete with a repeat Achilles rupture. But, you know, any single Achilles rupture on its own, when you're trying to restore that biomechanical connection between the muscle and the tendon, sometimes it doesn't get perfectly restored. So muscles have what we call this length tension relationship, where depending on the length of the muscle, it can generate a certain amount of force that transfers through into the tendon. So whenever you take a tendon, think of it like a rubber band. You take a rubber band and it's got a certain amount of stretch to it, right? That's your normal Achilles tendon. If you take that rubber band, you cut it, and then you insert a length of a different elasticity rubber band, and now you go and you pull on it, it's going to move different, right? And that can be what basically happens with an Achilles tear. Sometimes that tissue that goes in and the repair, the scar tissue that develops, that length force relationship isn't quite the same as before, and you can have weakness. So weakness is probably the big side effect you worry about, of course, right, with an Achilles tear. We're so good at rehab techniques, the surgeries are so good right now that that's less and less likely to happen. But I would think just with each subsequent Achilles tear, right, you can have that same sort of thing happen. And so obviously, complications with healing, wounds, etc. But thankfully, I can't think of any professional athletes who have had any repeat Achilles tears that I'm aware of. All right, let's see. David. ACL replacement 10 years ago. About our ACL replacement 10 years ago. My knee aches when it's cold. Is that normal? Would be an issue for Mahomes, Parson when they play. Good question. So a handful of things that go into this. Anytime you've had a trauma to the knee, you have an increased chance of developing what we call post-traumatic arthritis, where you have arthritis that develops in the knee that occurs at an earlier age than it otherwise would have if you hadn't had trauma to the knee. Trauma to the knee causes changes at a cellular level that can influence how arthritis can present and develop down the road. So I don't know specifically in your case, but that would probably be the most common thing in somebody who's 10, 15, 20 years out from an ACL. Some of that stiffness could very well be related to some arthritis in the joint. So yes, that type of thing can happen with anybody, including a professional athlete. Typically, though, it's not going to happen quickly. It's going to happen, 10, 15, maybe 5 to 10 years down the road. And so a player like Mahomes, right, who's already kind of at the back half of his career, I wouldn't be as concerned about it causing a major impact, because I think by the time it causes a significant impact, he's probably going to be out of the league and not as mobile anyways. I worry about it more in like a rookie wide receiver who's got maybe a 10, 12-year NFL career. It might start to catch up to them at the tail end, but not everybody develops that. Everybody's on kind of a different pace for all that anyways, and sometimes it just might get sped up. Sometimes it might stay the exact same. So yeah, that is, I wouldn't say it's normal, but it's not unexpected. It would be something that a surgeon would say, well, yeah, that absolutely can happen, but you're not going to not fix the ACL. Like, that post-traumatic arthritis isn't because of the ACL surgery. It's because of what happens to the knee when you tear the ACL. So you're going to still do the surgery. The surgery itself doesn't have anything to do with it. It's the initial injury that starts that cascade that can cause it down the road. Literature regarding kids growing up playing and focusing on only one sport in preteen and teenage years, and all that time increasing the chances for injuries in their adults. I'm not aware of any connection with injury risk, to be honest with you. I'm not aware of any data that shows injury risk with sport specialization. And you'll find different cases on both sides, right? Somebody like Roger Federer, who played multiple sports and ended up doing amazing, and Tiger Woods, like the absolute poster child of being a single sport athlete, who greatest golfer of all time. So yeah, I'm not aware of anything with injury risk and sport specialization. Let's see. Not sure what this was about. Comment back. Any substantial proof to those Twitter accounts that watch how athletes run and land and say how certain characteristics make knee and Achilles injuries more likely? No, I don't think so. I don't think there is. Now, I can't say specifically what you're referencing. I don't know the specific accounts or what you're talking about. It's funny because we've done so much research with doing like box jump landings to try and figure out if that has anything to do with ACL injuries. So, right, I think if I pull this up here, right, I think most people have seen these pictures, of somebody, and it's like, oh my gosh, their knees, like, look how much their knees buckle inwards. I'm not aware of any study that's watched like people jump off a box and land, and with high accuracy predicted who's going to tear their ACL. There are certainly some movement patterns that predispose you, but in these settings, right, the camera's positioned very perfect. You're trying to measure things as objectively as you can. So sure, can you get some information out of something like this? Yeah. Trying to dissect down like the exact angle of something on social media, I think is really tough. And Achilles, I don't know how anything could be related to the Achilles. Like there's no specific movement pattern that I could identify watching video. And I've spent thousands of hours analyzing like injury video. Definitely for the Achilles, there's nothing I can think of that is going to have anything to do with watching like movement patterns and trying to say, oh, you're at risk. And it's like, okay, if someone says you are, well, then what do you do about it? And that's the actual key. It's not just identifying. It's like what you're going to do about it. Craig, not sure who your student was, but glad to be helpful. Let's see. Yeah, Philip Rivers. Yeah, I'm definitely worried about him getting injured. Not just because he's been out of the sport for so long, but just his age, right? I mean, we see injuries and risk for all these different injuries go up as players age and get longer into their careers, right? And so just being 44 compared to being 35, you're going to be at higher risk. I think of the soft tissue stuff. I think of Achilles. He's not running. He's not mobile. He seems like he's doing a really good job of getting rid of the ball. So I think that the tendon injuries would be the bigger thing I'd worry about, like the patellar tendon, the quad tendon, Achilles tendon. Those would be the bigger things that I would be concerned about for him. So, John Mack, welcome. Thank you for joining. Ask any questions you got here. How intense was Mahomes' checkup with the doctor that performed his surgery? I'm assuming there's a lot of prep that needs to occur before surgery, like not eating and such. What did you imagine happening? I don't think this was a big deal at all. I mean, I think that Mahomes' surgeon got the MRI pretty quickly, looked at things, said, yeah, I mean, in that case, it kind of matters what the exam shows. For the LCL, for the posterolateral corner, the exam is important. For the ACL, the exam is not really that important. The MRI is. And so I'm sure it was just, hey, here's the plan. Here's your recovery going to be. This is what it is. And Patrick's known enough guys who's gone through ACL surgeries and stuff that it's not like you've got to have a big lengthy discussion of what is the ACL and stuff like that. They'll go through the consent process. Sometimes you got to remember too, sometimes these athletes have other health problems that we don't know about, right? They can have other medical history that needs to be considered when you're putting somebody under anesthesia, right? They could have issues with their heart, lungs, some other congenital things that can cause complications with anesthesia. So that's probably the bigger thing, is just understanding like the rest of his medical history and making sure they're not missing something for the safety of putting someone under anesthesia. But yeah, no, I wouldn't think much of it. Brian Branch fan would love your thoughts on his Achilles injury. Will he be back next season? Do you think he'll be the same player going forward? Yes, we will get to that question. Josh, welcome. Get your questions up. We will absolutely get to them. How old is Brian Branch? That would be my question number one. Feel free to type it back in here and see if I beat you to it. Brian Branch is 24. All right, that's good. He's a defensive back. And did he have surgery yet? Do we know? Let's see if we can find anything. Yeah, it looks like he had surgery December 10th. So surgery December 10th, you assume 9 months on average. So that takes us to what, like September? So yeah, I think he definitely could be back next season. It's not so much like how the surgery goes, right? It's how his recovery goes, and a lot of that's hard to predict until you get that first month or two into it. I think then the other questions that come into play, right, is so much of sports medicine is not just like what was done, but also what's the time point in the season with what could be done or what we have to consider with upcoming schedule. So if somebody, for example, had a surgery for their Achilles in mid-January, 9-10 months gets them back October, November. If you're trying to get back for a team that's not doing very well and is out of playoff contention and there's no like risk to push it, then you're not going to push it. But on the other side of it, like let's say the Lions are playing really well, he's ready to go September, October. Yeah, I would fully expect that he could be back next season. And he's young enough that I would expect if everything goes well that he'll be just as good the player as he was before. He's young enough. He should heal great, unless he's lazy or something like that with his rehab. I would fully expect him to make a full recovery. Now, we always expect everybody's going to make a full recovery, right? Nobody expects you're not going to do well. If you do enough Achilles surgeries, and there's enough NFL players with Achilles tears, some of them are not going to do better. And so that's always a possibility, but I can't think of anything with, position, age, timeline, that says he won't be back next season and won't be back the same player he was before. So, yeah, excellent. Great timing on this question, Josh. Let's pull up that video. So I was wrong on this one. I got some fun comments on it in my video that I posted. Let's move this over a little bit so people can see if they come in what we're talking about. Yeah, so it's always interesting to me, right? Like they'll show a guy with blood pouring out of his nose or a finger that's all cut up, but they won't show someone's knee or ankle go a funny direction. So let's kind of wind this back and take a look here. So I really thought that this was going to be, I thought this was going to be more likely a knee dislocation, a knee injury, as opposed to a leg fracture or an ankle fracture dislocation. And so what you got to look at here, right? This was, I think it was his right foot. So right there, how his foot gets bent underneath him. This is that, if you really pay attention to this externally rotated position. So right here, his foot is neutral. His toes are pointing down at the ground. Sorry, I can't make this any bigger. Maybe I can a little bit. There we go. Look at the position. His toes are pointed forward, neutral. That's good. The ankle joint is happy. As he goes down, that foot pointing outward, that's that external rotation. So that's the position you see that leads to the high ankle sprains, leads to these ankle fracture dislocations. And then as the play continues, it just gets rolled up underneath him. So this is putting a severe amount of that external rotation through his ankle. When he rolled over and kind of rolled through the play, this was why I thought that it was going to be his knee, just because of the almost like, 90-degree angle out to the side that we saw his tibia relative to his knee. I think looking back at this, of course, in hindsight, I think what's happening here is he's getting a lot of hip internal rotation. So the hip internally rotating this way is going to cause that foot to swing outwards. And so that's probably why his knee looked like that. So this was just a matter of the knee, the ankle is what took the brunt of this force rather than the knee. You'll commonly see, though, when somebody has a high ankle sprain, they could also have an MCL sprain because it's such a similar mechanism, and like a similar position that can injure everything. But yeah, thankfully wasn't the knee. I will say though, I think the involvement of the ankle is always more concerning to me, just because that introduces more potential for cartilage damage in the joint. If it's just the bone that breaks, like just the tibia, the shin bone, you easily fix that. That's not that big of a deal. But anytime a joint is involved, there's more potential for damage to the cartilage. And that damage to the cartilage is what worries me longer term, because that's harder to fix than just bone or just the ligament. So I think the worst case would have been dislocating his knee. Second worst is dislocating the ankle. The best case would have been if it was a tibia fracture, but the joint was spared. And so now, knowing now that it was a fracture dislocation of his ankle joint, to me is kind of the second worst, because that tells you there could be some potential for cartilage damage inside the ankle joint. For a running back, that's going to be potentially more damaging than just a straight up broken bone that you can pin and fix. So hopefully that answers the question. Thank you. All right, let's see. Yeah, this is a good question. Any sports where you serve as a member of the medical team that are more challenging if an injury happens, you need to provide care? I assume football stuff due to the pads. Yeah. Ice hockey. So I don't do it any right now, but I did a bunch of ice hockey coverage in my training. I trained up in Minnesota. And so obviously, like, hockey is life up there and everybody plays hockey. And so I did a ton of hockey coverage, and it's hard, right? Because you're slipping around, you're sliding around trying to get out there on the ice. Guys have sharp skates, their pads are huge. Like, it's really hard to get a skate off if you're trying to look at someone's ankle. So hockey, by far and away. Football can be tough just because of the shoulder pads in particular. Like, if you're trying to examine someone's collarbone or like chest and they're all sweaty and you got to get up in their shoulder pads or then try to get their shoulder pads off to do something, it can be really hard. The other thing you don't think about too is these guys like tape up and spat and do so much bracing to their ankles and knees that sometimes you're out there trying to examine an ankle and it's so taped up and spatted and covered in braces and sleeves, etc., that it's hard to like really accurately get down to stuff. So 100% hockey. Hockey has absolutely been the hardest thing that I've had to cover because of equipment. Yeah, that'd be cool. Don't think that's going to happen. It would be pretty cool though. Let's see. This is kind of an interesting thing some people might wonder. I've only like once or twice ever gotten messages from the athletes I covered. One time was really bad. One time was really good. There was a boxer. I can't even remember his name, but I did a video on like 4 or 5 years ago who there was some translation issues. They thought he had torn his Achilles. He had or hadn't. I can't remember. And I did a video kind of like, I don't know if you're fighting 8 rounds on a ruptured Achilles. And he sent me a pretty nasty message about it. Another time was a very good one. It was an athlete that I covered a video on, and they sent a message. I think though, I film all these videos as if I would like talk to the athlete because it helps me be professional about it. And so I film all of them with the assumption that the athlete is going to see it. The same way I film all of them that I have the assumption that the medical staff is going to see it. I don't know if the Old Dominion I don't remember if the Old Dominion football situation happened since our last office hours. Do I still have that in here? But I mean, I was pretty critical of what we saw with the Old Dominion football team and kind of what happened there, and the questions about what's the deal with all this? And I make that video with the full intent and knowledge that they're going to see it. I think you have to, and that helps kind of keep things nice and professional. So everything I cover, I try to cover it with the intent that the athlete or their staff or team or parents or whoever's going to see it, and maybe they'll learn something themselves from it, maybe not, but that it's just a good way for me to try to stay professional with all of it. Yeah, I don't know. These teams, the 49ers are another one that I think about, where like the 49ers have had so many injuries and like player injury lost. I think it's hard because unless somebody really teases out like the contact or the non-contact, like Fred Warner, like you can't chalk that up to like injury prone or bad training or strength and conditioning or the medical staff. I think the things you can are going to be like the hamstring strains, the quad strains, the soft tissue injuries. I think absolutely if you've got a team that's having a rash of hamstring strains or quad strains or calf strains, I think that is something you can take a look at, what's the medical staff doing differently or could they improve on. But I think a lot of it, more than anything, is just bad luck. I think unless you can tease out the soft tissue, the contact, the non-contact, it's really hard to blame stuff on the training staff. And also these guys like do so much on their own and have their own training staff. Like we don't know the TJ Watt situation. Like we still don't know if that was a Steelers staffer, if that was like his own personal person that was in there taking care of him, that was doing the dry needling and caused the collapsed lung. So it's not always just the medical staff for the team. Sometimes it's their own individual staff that's playing just as much a role in helping or harming their recovery and stuff. Let's see. All right, with many NFL concussions coming from whiplash and helmets hitting the ground, you think the NFL players did neck workouts similar to F1 drivers? That could help with the whiplash. Yeah, great question. So the idea with this in like F1 racing and boxers, a lot of boxers do this too. Whenever you're, like if theoretically everything just moved together, this is going to look really weird to people who don't know what I'm talking about. When everything just like moves together, that's going to be less likely to cause a concussion, like without a big hard impact. The whiplash he's referring to, right? Whenever your head whips, your brain is moving inside your skull and your brain is like, boom, your brain is slamming into the side of your skull and there's just much bigger impulses of energy transferred into the brain. What F1 racers, what a lot of boxers will do is try to strengthen the neck muscles so that your neck muscles can do a better job of keeping your head stable and not allowing all that whiplash. That's part of why when you see a fighter who, like I think of Canelo Alvarez all the time, like Canelo, like he's got this big broad neck and he's always kind of in this position where his head seems to be ready for an impact versus somebody who's just kind of like floppy going around, right? They get caught off guard. Your muscles can't fire in time for you to stabilize your neck and help. So yes, there is some data out there showing benefits in reducing concussion risk. in teams that have done some sort of neck strengthening program. I don't think it's like most stuff, right? I don't think it's conclusive enough that you should like demand every player do it. But I think that's actually a really good thought that I haven't thought of. I think if you've got a player that like a quarterback, I think is a good example. So somebody who's got a high chance of getting like hit and swung back on their head. I think quarterbacks, that'd be a great thing to think about incorporating is could you do anything to it? You know, they talk about trying to fall the right way. Some neck strengthening stuff, some of them might already be doing it anyways. But if they're not, I don't think it could hurt at all as long as you're doing it the right way. Mike Tyson has some old videos of him like doing these headstands and rolling around on the top of his head. Don't do that. Like your head doesn't need to be axially loaded, like pushed downward. You just need to like have the side to side stability and strengthening. I think it could absolutely be helpful. Yeah, great question. I think it could. I don't know of any NFL data, but extrapolating from other sports, I think it definitely could. All right. Do I cringe when soccer players attempt headers with the ball? Yeah, I've never played soccer myself, but yeah, it seems like it's got to hurt and not be comfortable for a ball to be flying through the air from all the way down the field and then smacking the side of the head. I think there's a skill to it though, right? Like in terms of where the ball hits them and how they do it. Soccer actually has some of the highest concussion rates in like all of college sports, and so there are absolutely not necessarily from heading the ball, but just from the head-to-head contact when you go in to head the ball. Yeah, I mean, I could never be a soccer player either. I'd be too scared to hit my head and do something funky with all that. All right, let's see. Teams going to full grass does not make as much difference as everyone thinks. You know, I think it makes a little bit of a difference, but I don't think it's as much as everybody thinks. Micah Parsons tears his ACL. It's a grass field. Daniel Jones, I can't remember if Daniel Jones was on a grass field or on turf with his Achilles. I think he was on a grass field too when he tore his Achilles. You're going to have these injuries on all surfaces. I don't think there's harm in going to grass fields, but I don't think it's as easy as all of these teams make it out to be, right? Player like, oh, what's the big deal? Just put in a grass field. I don't think it's that easy. I think there are truly more logistics to it that is easier said than done. At a lower level, because I think about things not just NFL, but like high school, college, because there are far more high school, middle school, college football stadiums around the world. And I think at that level, it's far easier to maintain a turf field than it is to maintain a grass field. And so I think at that level, the turf fields make more sense because you can put it in, it's the one-time investment, and it's going to hold up better throughout the season than a grass field can get beat up, like relay saw, there can be big holes in it. And so I think the key is having a good quality field. I think at the NFL level, when they have good resources, yes, if you're putting in a new stadium this day and age, I think you should put it in with the intent of it being a grass field. The older ones, I can understand why they don't want to spend all the money to renovate and have to, especially different climates. It's not that easy to grow grass everywhere. But I think at the lower level, whatever is going to be the best quality field, and oftentimes that's turf. A lot of our high schools around here in Missouri have turf fields because it's just easier. It's just easier to maintain, and that maintains a more consistent quality of field. Yeah, I don't know. I'm not sure about this. Surely the newer ones are not concerning in that regard. Let's see. How often do medical training staffs review what they did, how they can improve, and make sure they didn't break protocols? Assume it's following every game, maybe weekly, monthly. Yeah, great, good question. So we will with the medical staff I work with, we will review um, we'll review situations after the game if we all felt like it was a higher risk type of thing. I recently at a football game we had a bystander in the crowd who had cardiac arrest that we were there to respond for, CPR, et cetera. And so after the game, our whole medical staff, the athletic director, we all sat and met and did like a full 30-minute debrief on like how did it go, let everybody give feedback, what could we have done different, what could we improve next time. And I would do the same thing. Like if we had an athlete that got spine boarded, we'd absolutely sit and review it. It's definitely a standard protocol. What's harder to predict is like if your staff identifies it as something you should sit and review, because I think like the whole thing with this Old Dominion, just to talk about this, because I don't think we covered it last week. I think it happened after last week's video. The whole thing with this one isn't, I think I tried really hard to kind of accurately describe what my concerns were with this, because I don't think that there's like bad intentions on the part of the medical staff. I don't think they're like, oh, they should be fired, or like, how dare they, or that they knew the kid had a concussion but said like, screw it, we don't care, he's going back in. We have the benefit of seeing replay of all this stuff and seeing what transpired. But I can tell you from being in a college football team where I'm covering with the medical staff, you don't like easily have replay to look at. And I think that that needs to be instituted as part of the review process, because yes, on TV replay in real time, it looked like he was unconscious. I mean, to me, it looked like there was no doubt. You know, we can see his arms go limp. He doesn't try to brace his fall. That's a very clear sign of being unconscious. The whole sequence, even before this, like, I mean, he's just like laying here on the turf, not moving for at least a few seconds. But the medical staff truly might not have seen that. Like, they might have gotten out there, and by the time they got out there, he was conscious, and then they get him off the field. And if he says, oh, everything's fine, I feel great, answers the questions appropriately, I can understand how you can potentially fool the exam. And so I think, like, what I would review in this situation would be, okay, is there a way we can review video? Because that's made a huge difference in the NFL, that it's required for them to review video, because we see these outward signs, right? People say, oh, you weren't there, you can't say he had a concussion. If somebody postures on the field, I can tell you he had a concussion. I don't need to be there to examine them. And that's helped a ton in the NFL. And so I think in college, we will start seeing that trickle down, where teams are going to be required to at least say that they reviewed video. Because I think if they would have reviewed the video, they might have had a different impression of like, ooh, yeah, this looks pretty bad, and probably would have spent more time taking it back into the locker room. The other thing that I thought was concerning about this is, I know he was out of play. There was a big injury review or targeting review in the meantime, but I recorded the time on the screen and live real time, like until he was back on the sideline with his helmet. It was only like 5 minutes. They also had to address a nosebleed. So to be able to do like take care of a nosebleed and do a thorough concussion assessment is really tough in that amount of time. And so I think that's the other thing to look at is, hey, what assessment was done? What were the concerns? But I think the video review is the big thing that I would absolutely add back in here. So yeah, go refresh. Yeah, go refresh the page. I put one up like 3 or 4 hours ago talking about it. So yeah, it's disappointing. It's disappointing to see him say he thinks concussions are all in your head, which, I mean, technically he's not wrong, right? Oh, sorry, you said you just hadn't seen it yet. Antonio Brown, yeah, I don't know. I mean, like, Antonio Brown's like the poster child for people thinking that a couple of bad hits leads to CTE, and we might find out, in years whenever he passes away. Hopefully it's far more longer than years. Who knows if he'll have an autopsy done or not whenever that day comes, but that's the only way to diagnose CTE for now. So all this other like, oh, he's got it, he doesn't have it, who knows? I'm not going to even start to speculate on somebody like Puka. I mean, I think that would be irresponsible to speculate if he has CTE or not. Just the education part is what's frustrating, right? And that's such a deep-rooted, going back to junior football days, that you're not just going to like flip a switch and, oh, yeah, okay, I think differently about concussions. So I think what we're going to try to do with our football team this year, my universities, is do like a preseason education session with all of them, and go through and let them ask questions, talk about head injuries, something we should probably be doing anyways. But I think we're going to make a stronger point to actually do that sort of thing. All right, we got a super chat here. Appreciate it. Injuries more so biology, injury prone or bad luck. Vikings fan. This question is based on JJ McCarthy, MCL ankle, concussion hand. Could you say the same about Burrow, for example? So I think there are components of both. I think certainly if you look at ligaments, if you just, for example, take somebody's MCL and you cut it out and you put it in a lab and you pull on it from both ends to try and see how strong it is, there's going to be like a bell curve. There's going to be a certain, depending on age, depending on some other factors, genetics, there's going to be a certain elasticity, tissue property, stiffness, etc., to that person's MCL that is not the same as somebody else's. This isn't like a Toyota Camry where you can take an axle off the shelf and it's the exact same from one store to the other. Everybody's biology is going to be a little bit different. Now, usually that difference is not enough to suddenly make a huge impact on injury, but if you combine it with enough other things, then yes, absolutely. Um, there are other external things, right? In case of Achilles tendons, there's a class of antibiotics called fluoroquinolones. And if somebody takes long-term fluoroquinolone antibiotics, that can increase your risk of Achilles tendon ruptures because that actually modifies the tissue properties of the Achilles. So yes, there are absolutely biologic things that make somebody more likely to get an injury if the right force is applied through that tissue. Some of it, though, is just bad luck, right? Like your concussion is bad luck. It's not like you can train your brain to not get concussed. The hand, like someone hits them on the hand, that's nothing you can train. Sure, could you have low vitamin D or like a genetic condition that affects your bone density? Yes. We're going to assume that a player at JJ McCarthy's level does not have some genetic inherited like bone density problem. So I think there's twofold. I think most of it is luck. I think most of it is bad luck. But I do think that there is a genetic component that in most cases we don't understand, right? There's some inherent risk factors there that we try to train out of people and we try to address with strength and conditioning training, sports science, etc. There's nothing about JJ McCarthy though that would make me think he's more in that injury prone category than he is in the like, just bad luck category. Now somebody like Lamar Jackson, I'm starting to maybe have different opinions on someone like Lamar Jackson. It's like every week he's got something else in practice that's bothering him, and I don't know if it's like a pain tolerance thing or if he truly is just like getting hurt every week. But when I start seeing like, oh, he's on the injury report with a toe, now he's on the injury report with a hamstring, now he's on the injury report with a knee, you wonder if that's like higher injury prone or if they're just more sensitive to these little bumps and knocks. But yeah, hopefully that helps answer the question. Burrow, I think the same about Burrow. I don't think there's anything about Burrow that makes me think he's more like crazy injury prone or anything. Guardian caps, $1 million question. Good question. We'll get to it. Boy, time flies. It's already 7:50. Okay. Yeah, so guardian caps. If a parent came in and asked me, is a guardian cap going to reduce the chances my child gets a concussion, I would say possibly. Is it going to prevent my child from getting a concussion? No evidence it's going to prevent somebody from getting a concussion. If you take a pillow and you strap a pillow on top of someone's helmet and you hit their helmet, it's going to cushion their head. Like you can't lie about the physics there. But if the guardian cap does it in a meaningful enough way to limit concussions, all of the studies that I've seen that have actually looked at concussion as an endpoint have not shown any benefit. Our university wears them. I would, if they asked me, should they be required? I would say no. I don't think they should be required. The other thing you have to think about is the guardian caps that you can buy for like your high school kid are different than the ones that they get for like NFL and college. The NFL college ones are thicker. And so uncertain how much that has changed in the different testing. And your point about risky behavior is absolutely a concern, right? If you market something and say, oh, it's going to prevent concussions, you're fine, you're protected. And then some kid just goes out and like spear tackles everybody recklessly. That's absolutely not good. And that's my biggest concern with all these things like the Q collar, all these like concussion limiting, lowering devices, that it gives people this false sense of security. And then they go and they play riskier and they don't take into account rule changes and other things we know are going to help. So yes, I think the guardian cap has been misunderstood. And again, to guardian cap's credit, they don't market it that it's going to limit concussions, but I think it's easy to take advantage of the perception that's out there that they are going to prevent concussions, which I don't think there's any evidence they're going to prevent concussions. They're going to decrease the force, sure, but is it enough to influence concussions? I don't think so. You're welcome. Appreciate it. Thank you very much. Let's see. Overtraining young athletes, specifically guys who fight. Yeah. Yeah, that is a big in-depth question. Overtraining is an absolutely real thing. The one pearl that I will leave you with is this. Because honestly, like I would get into like any of these ChatGPT LLMs, and search for relative energy deficiency syndrome, REDS, REDS. Used to be called female athlete triad. We've appropriately changed the name to relative energy deficiency syndrome. particularly common in females, where literally what it says, they have a deficiency in energy, and this causes a multitude of problems. There's really three issues with like eating, things like anorexia, bone health problems, so they're high risk of stress fractures, and then amenorrhea, so their menstrual cycle gets out of whack and they stop having periods. It is not normal for a female who has already started to stop having periods. Sorry if this is like TMI, but important lesson. Anybody out there with daughters, females in their lives that are high level runners, etc. The number of high school and college athletes I see with stress fractures who you ask if they have regular periods and they say no is extremely high. And so that's the one thing to just like be aware of and be thinking about. You can let your wife do the discussion about all that. But if anything starts to become abnormal with cycles, that's important to think about, stop and assess and say, hey, where is energy deficiency coming from? Because that can cause all kinds of things down the road if it's not properly addressed. So let's see. You are all very welcome. Yeah, ways to check for CTE without removing the brain post-mortem. I will admit I haven't dove deep into this research in like the last maybe year, so there could be something I just am not aware of yet. There are some clinical testing standards that are trying to be used for research purposes. Last I checked, to try and like research studies identify who might have CTE. I am not aware of any imaging studies, but I think as good as our imaging studies are getting with identifying things like, you know, Parkinson's, etc. Yeah, I think eventually we will. I think eventually we will have a reliable way to, in someone's living life, diagnose CTE. But I don't think we're there yet. All right, let's. I'll keep an eye on the chat, but I want to go over to this and make sure we address any of these questions here. I think we've kind of talked about the Achilles injuries. Updates on Jordan Love, Lamar Jackson. It sounded like Lamar had an MRI that was okay, just showed a bad contusion. Contusion is a bruise, so I would think he will be just fine. Sounds like Jordan Love is expected to practice, right? There's a 5-stage protocol, 1 stage each day. He can very well get back. I think the Packers don't play again until Sunday, if I am understanding correct. If they play Thursday, then no, I don't think he's going to be ready. But let's see, Packers next game. Saturday. Yeah, so I think he could be ready. So I think everything so far is pointing towards him being okay and ready to go. Best way for an athletic trainer to make it to high D1 or work for a professional sports team like basketball, football. You're not going to do that as your first job. So unless you are somehow able to get like an internship with one of those teams and then just really knock it out of the park, most likely what's going to happen is, you know, if you can go to a school for your athletic training master's degree, and then maybe get hired on to stay at the school, or get a job at like a FCS, you know, Division 1 or a lower level Division 1. And then there's so much demand for athletic trainers. Eventually, if you know, get enough experience and build up experience, you can get there. You know, a good example, our current athletic trainer, head athletic trainer at our college, we're FCS Division 1. He came to us from Kansas and was the cross country athletic trainer at Kansas. So he's at a big, you know, Power 5 university doing a lesser sport, you know, compared to football, basketball. And now he's kind of moved over to a lower level university, but our head guy and doing football. And so there's kind of like a little stair stepping that you can do to kind of get through all that. Yeah, I mean, I'll put this up here. Not my. I don't know at all. You don't want to be asking me that question. I have zero reason to know anything about that question. So sorry. Yeah, trust your OBGYN, I guess, is all I can say. Sorry. Wish I could help, but I can't help with that. Yeah, the Discord. It's basically you just have to join the YouTube channel membership, and then you can connect through there. If that becomes a big issue, then feel free to message me about it, or we'll figure it out otherwise. One last question here. Where was this? Not unaddressed. Replays lack their own. Do I get better looks with the all 22 film that comes out? Yeah, sometimes. Usually though, I'm just like eager to get the video up as quick as I can, that I'm not going to wait for the all 22, and so we'll kind of go off of what we have. Usually there's enough angles that you can pick up what you need to pick up to discuss everything. That is everything over there. Let's head back over to the chat. We are at an hour. It doesn't seem quite as busy this week, but that's okay. Still, hey, anytime I'm continuously answering questions sounds good. ADHD does increase risk for concussions to be worse. Yeah, this is an interesting point. So any sort of pre-existing, anxiety, depression, PTSD, pre-existing migraines, sleep disorders, all that can get made worse when you have a concussion, because it's all kind of coming from the brain, right? So the same way a muscle injury can get worse if you injure your muscle. A brain injury can make these brain mediated things get worse for sure. Let's see. Out of all the limbs and bones and muscles you cover because of various injuries, what is the one you really don't like to cover because of it being overly complicated or overly simple? Honestly, my first thought with this was the Achilles tears, because the Achilles tear now, like, there's so many replays of it. It's like, there it is. Like, what else is there to talk about? The other ones though, where it's like the foot injuries, the shoulder injuries, the elbow, the hand, the wrist, where you can't like obviously see something snap or rupture. People have gotten really good now, right? With the Achilles, it's like, yeah, we saw the pop, like it's an Achilles. And so I have to figure out some other like interesting angles to work in to do it with the teaching points. ACLs are kind of getting to be that too, almost, where people can recognize that non-contact pivot, movement, pop, etc. So those are the ones that get a little bit more monotonous, but still okay. All right. Anybody still here? There might be like 2 people watching. I can't tell. I have no idea. I don't pay attention to how many people are watching live. I think we answered every single question, which is great. There's nothing else in here, nothing else in the chat. So we'll call it there. Everybody have a great holiday. Have a Merry Christmas. And see you back same time, same place next week. Thanks as always, everybody. Appreciate y'all.